Hello, welcome to a short special session oriented towards Gyn Onc Fellows and other clinical colleagues who need to deal with staging issues in gynecologic pathology. I'm Dr. Louis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center, and I'm really pleased to be able to share this program with you. We're going to cover several different issues having to do with staging, lymph nodes, and a variety of other issues that sometimes can be problematic. So we'll just talk a little bit about the measuring issue, which is obviously a big part of staging in many tumors, but most especially in the vulva, cervix, and other more superficial sites. This is one of the staging distinctions in terms of depth of invasion and so forth here and elsewhere in the uterus and the cervix. So the standard definition for how to measure in the vulva is here taken from the CAP protocol, noting that the depth of invasion is measured from the adjacent most superficial dermal papillae to the deepest point of invasion. Now that seems fairly straightforward, but in practice, actually, there are a variety of challenges that this presents. And that's particularly when you're uncertain about what's true invasion, or when the sample may be somewhat wrinkled and what the level of invasion is present. An alternative method, which has some data in support of it, is to measure from the basement membrane of the deepest adjacent dysplastic reedy ridge to the deepest point of invasion. Now, this obviously would give you smaller sizes and less cases in the 1B category. However, these downstaged patients do have fewer recurrences and a higher survival compared with overall stage 1B patients in that, according to that method. So while additional data may be helpful, this is something to keep in mind as an understanding. So what's going on here and what are the issues? Well, here's one of the issues that makes depth of invasion a challenge. So here we see a somewhat undulating surface that has intraepithelial neoplasia here on the left and an area of invasion. And the question is, where is the proper point to measure from? And what is really going to represent the true depth of invasion for this case? So here we see in the blue measurement, obviously the longest depth, over 1 millimeter, to this deep nest here. But you kind of scratch your head at this and go, does this really represent that depth of invasion, or is the surface here just wrinkled and stretched out, or not stretched out a little bit? And maybe the real true depth of invasion, biological depth of invasion, is something more like the red bar or the yellow bar. So this is an important factor to remember, because the vulva is not a flat surface. It has undulations and redundancy in areas, and it's not always pinned out or stretched out to be flat when it's received as a pathologic specimen. So there's a degree of subjectivity here, and different observers, different pathologists will measure this differently. But being aware that this 1 millimeter cutoff is significant in terms of making a difference in terms of inguinal dissection is an important thing to bear in mind when you're making that distinction. So the alternative measure, as we indicated in the CAP protocol, is taken from this work here. And I think you can see here in the diagram what the difference is. So here is the depth of invasion to the highest reedy papillae, whereas here from the deepest reedy ridge here to the deepest point of invasion. So obviously red, much smaller than the blue. And here we see that illustrated in several components. So here's the conventional way, blue down to a deep invasion, probably over 1 millimeter. And so this is going to end up measuring a fair amount of hyperplastic or hypertrophic in situ neoplasia more frequently, and then potentially upstaging cases that biologically may not be truly upstaged. Whereas we look here where we've got, keratinization, aberrant keratinization up high as well as down low. Here's our the projected measurements, and there's very little distinction. And panels C and D, you can see there is a bit of distinction, and some judicial discretion in terms of where you choose to measure from as well. But this is the issue that this method seeks to take into account: the thickened in situ component that may accompany early stromal invasion, and defining that at-risk invasion as being true depth of invasion rather than just a combination of in situ and early stromal invasion is probably, at least theoretically, a reasonable thing to think about. It's also important to remember that tumor thickness is not the same as depth of invasion. So tumor thickness is the full thickness from the surface to the deepest point of the tumor, whereas here with the standard method or the alternate method, you can see that these depth of invasion would be measured at vastly different areas. So even though something may clinically have a thickness of several millimeters or even centimeters, sometimes that does not represent the true depth of invasion. And this is particularly true for verrucous lesions, for lesions with pushing pattern invasion that can be quite difficult to measure or determine even the presence of invasion at times. Well, for those who are not pathologists, it's important to understand how sectioning and orientation of the sections can influence the depth of invasion measurement. So if we look here on the left, where we choose to section, what we choose to sample, and how that is cut and oriented may make a difference in terms of the depth of invasion that we end up with. So if we were to use this portion on the left here, that would give you a particular depth of invasion down to here, which may not be the deepest point of invasion, as you can see from the tumor contour. Over here would be even smaller. If you take a section through here, lay it down in the block, you would get less depth of invasion. But sometimes, for various reasons, these sections that are taken may not be entirely perpendicular to the surface. It may be related to how the tumor is oriented, what the anatomy is of the location. Cervix, for example, has a rounded surface, and so knowing what perpendicular angle you should take can be a difference. Additionally, when you have a biopsy sample, that may come out as something that looks like this piece here. You section through the middle, through the red portion, and then you lay it down flat in your tissue block, and then it's embedded in the paraffin block for sectioning. Well, when that's done reliably and reproducibly, you're going to get clear separation of epithelial component from the stromal component that's deep. And you'll be able to provide measurements on that basis. So your slide's going to look something like this, where you've got epithelium on one end and deep stroma, subcutaneous fat on the other end. But if for whatever reason this alignment is not true, if the biopsy is difficult to orient, if the knife slips or other things happen, or it gets moved around in the processing block, sometimes you can end up with a situation like this, where the portion that's down consists entirely of either epithelium or stroma, or at least is on a bias, and so you're going to have a very difficult time getting an accurate measure of depth of invasion in that circumstance. And that's where you need to have almost good luck to be able to reorient this in a way that can allow you to get a reliable estimate. Sometimes it is just not possible. You try turning it, you may angle, re-melt the block down, re-embed it in a different plane, but you may have already lost the battle because the epithelium may be gone. So those are some of the challenges and some of the limitations of the technique that we use. go along with these important issues in terms of depth of invasion and therefore stage. In terms of measuring tools that are in use, certainly the standard tool for measurement of microscopic distances in a situation like this would be an ocular micrometer, which is something like this. As you see, it has a graduated scale that can be seen through at the focal plane of the tissue, and based on the magnification, you have to calibrate it for each ocular and each objective lens, so that you can say that at 4x, one space here is equal to 0.04 millimeters, or at 50x, this is equal to 7 microns or something of that sort. You have to do that, do the math on that, which is a little bit cumbersome, and you have to have a standard which you can go from as well to provide that depth of measurement. Now you can, of course, use some measure of internal controls to make sure that things like red cells or white cells or other things that have a fairly well-defined size can correspond to the appropriate number of demarcations at magnification. Now for less, when you need fewer significant digits, using a ruler, maybe a translucent ruler or some other graduated scale that can be used, then you can get several millimeters down to the millimeter level in terms of significant digits. Calipers, engineer's calipers, can be used if you have access to that tool and the particular tissue is amenable, or the gross lesion is amenable to that use. And then finally, more and more digital microscopy is coming into play, and many of these have calibrated measuring tools as well that can be used. Just a note at these, however, you shouldn't just accept them without further thought. You should consider validating these measurements using external standards as well, just as you would for any other critical tool you're going to use. Now, as we mentioned this with the cervix, there's again similar sort of rules that you begin from the basement membrane of the overlying epithelium, but because the cervix is kind of curved and has a lip before you begin the vagina, it's not entirely clear for different tumors where the point of origin should be for that initial measurement and where truly the deepest invasion is going to be. So it's maybe not a critical issue in a large diffuse tumor like this, but you can see that if your tumor is up here or if it's across a broad range, do you measure from the most perpendicular surface? Do you measure maybe from the squamocolumnar junction to the deepest point of invasion? It kind of depends upon a degree of understanding of the biology and the pattern of growth that you're seeing to be able to measure the deepest point of invasion. And this is why in cervical cancers we often need to provide lineal extent as well as depth of invasion to properly stage these tumors in terms of their likely behavior. Now, one thing that should give us pause is the fact that measurements will differ depending upon the stage at which it is measured. And this is a nice study looking at renal tumors, which generally tend to be round and fairly uniform, and so therefore we're nicely amenable to this study. But essentially looking at the distinctions between radiographic size as measured on CT scan or otherwise, gross size after excision, microscopic size after fixation of the tissue in formalin, and then finally a size measured from the microscopic slide, presumably after tissue processing, embedding, staining, and so forth. So not surprisingly, the smallest size here is the post-processing size, But these are not insignificant differences. If you look at the scale here, you're talking about 112% at the gross radiographic stage versus 86, 88% after microscopic fixation and sectioning and so forth. That's a dramatic difference that in many cases could certainly move you from one stage to another. And of course, this is why we preface the stage using the P code or the R code or C code or whatever. But it's important to indicate what your measurement is based on, whether that's a measurement from the slide, measurement from your gross exam, pre-fixation, post-fixation, et cetera, et cetera. Now, does the same apply to other tumors in other sites? Well, I think in theory it does. Certainly, formalin fixation causes tissue contraction. That contraction may be differential between epithelium and stroma. And so that distinction is going to be there. And the same would be true of microscopic tissue processing, dehydration, delipidizing the tissue, and so forth could also remove mass and leave you with a more compact structure. So let's talk a little bit about some of the issues in endometrial cancers where we have both grading as well as measurements that are involved. So first, with regard to grading, the FIGO grading system is based on the proportion of solid growth, where less than 5% constitutes grade 1 and greater than 50% constitutes grade 3. So this is not very much, and this is most of the tumor. But sometimes we get into trouble when we think about what constitutes solid growth. And that's one of the reasons why there is really only moderate agreement on tumor grade between pre-op endometrial sampling and final resection diagnosis. These grade 2 carcinomas tend to move around a fair bit. Now, you can use nuclear grading to upgrade in certain circumstances if you have higher grade nuclei than expected, and so forth. There are other systems that look at solid growth, necrosis, and so forth, but none of these are in wide use, at least in our institutions or other places where I have been associated. So here's perhaps some easy examples. The point I want to make here about grade 1 tumors is that these have open glands. You see a lot of clear space. Now, we also have here some separation between these glands. Trust me that there was a nice invasion elsewhere. We also have squamous metaplasia, and that does not count as a portion of the solid growth. So you don't include these squamous morules as evidence of solid growth in this tumor. Whereas over here on the lower left, we have, maybe a few glandular spaces, a few small open areas, but pretty much the entire tumor is mostly solid growth. Now, this is, I think, perhaps as good a gauge as any. You might say, well, some of these are glandular growth, but there are a lot of areas where you just can't really define there's much of a gland. And when you determine that that is greater than 50%, you can, of course, call it a grade 3. The materials in between, when you have some open space or have a few open glands, but you're starting to get more, compressed glands, that begins to cross over into grade 2, at least for me, into solid growth. So you may still be able to recognize it as an adenocarcinoma, but there's relatively little open glandular space that remains, or at least we'll say that there's a considerable amount of solid component. And that can be in the form of cribriforming, can be in the point of aberrant buds or elbows off of the glands and so forth. Now, when we measure depth of invasion in endometrial tumors, these are the cartoons from the CAP protocol, note D, and I would just emphasize the value of reading those notes from time to time. So if we have an invasive focus and we can see the endomyometrial junction up above, that's the depth that we measure to. If that is a more undulating surface, we go to the closest one to measure depth of invasion there. The problem that we more frequently encounter is We have clearly invasive tumor, but we may not have these endomyometrial junctions that are normal endometrium and myometrium on the edge. So we have a bulky tumor that is essentially replacing the entire tumor. So when these tumors are bulky and you can't perform a reliable estimate of that depth because you don't have any normal endomyometrial junction, you're left with two choices. One is to use an alternative method, which has been recommended to measure the distance from the serosa to the nearest invasive component, or you can approximate the distance. And since in terms of staging, we're just looking at 50% or under 50% as being the cut mark, usually we can do that. You can also use the outer vascular plexus. That's definitely into the outer half, generally about 2/3 of the way through the pre-existing myometrium. And so that also can be kind of a rough gauge for depth of invasion. The other problematic area is when we have involvement of adenomyosis. And in that circumstance, if the invasive tumor is anywhere near to adenomyosis, your measured depth of invasion is from that adenomyosis to the deepest portion of the tumor. Well, that's easy to say, but sometimes very difficult to put into practice for various reasons. But the principle is that this is believed to be a different biological progression, state of progression of disease compared to, say, the invasion from a bulky exophytic tumor. So let's just take a look at maybe some example circumstances. So here's a low power view. We see an endometrial tumor up above, lots of myometrium, and we've got tumor invading into the myometrium. So we think. We also have a slightly different appearance over here on the left, but based on here, somebody's marked this is the deepest area of invasion. This looks like tumor here. So probably we're at a 1B at least if we have no involvement elsewhere. So you'd measure maybe from here or someplace up in here to this point of depth of invasion. Well, if you did that, you'd be wrong. Because in fact, as we look a little more closely at this, you can begin to see that there's two things. There is stroma. There's a very pale purplish stroma indicating adenomyosis. And on the left here, we have benign adenomyosis. But also here on the right, we have a little gland, benign gland here adjacent to the neoplastic glands. And if we go even a little bit deeper in this section, even at that very deepest point, literally millimeters from the serosa, we have the same features that give this away as a carcinoma involving adenomyosis. So here's a benign gland here on the left. Here's our carcinoma that is involving adenomyosis. So in fact, this is a 1A tumor. It may still be a totally in situ tumor in that regard. So this again underscores the importance now of looking for adenomyosis and defining when it's present and bearing in mind that may greatly influence the biology of this tumor and its risk of progression or recurrence. So there are a few other problems in staging endometrial carcinomas. Of course, we've mentioned the exophytic bulky tumors that pretty much occupy the entire endometrial cavity. And then many times we get a friable or poorly fixed tumor that can easily be carried over to new spots like the serosa, the vessels, even the fallopian tubes and ovary can occasionally pick up these very friable fragments of tissue if we're not really hygienic in terms of cleaning our knife, cleaning our surfaces to make sure that we don't run the risk of artifactual contamination and therefore upstaging. Another challenge with these cases is that sometimes defining the lower uterine segment from the cervical margin can be difficult. And so tumors that are right up and against the beginning of endocervical mucosa, you can't always distinguish whether or not that's endocervix or lower uterine segment. And obviously, the cervix involvement, especially if it's myoinvasive, is going to change your treatment and change your management and stage. Additionally, isolated foci of invasion may occasionally be missed, but our staging criteria are relatively forgiving in that sense because a PT1A and a PT1B are not dramatic differences, and PT1Bs usually have much more readily identified established invasion. And finally, the issue of mixed tumors or dual differentiation patterns, such as in dedifferentiated endometrioid carcinoma, mixed serous and clear cell, mixed endometrioid clear cell, et cetera, et cetera. These can be more difficult in terms of both correctly staging and classifying these tumors. Well, another area where measurement and these issues come into play is in lymphovascular invasion. So this is an important feature to understand where the possible pitfalls might be and where we might need to be careful. So tumor retraction artifact is one of the pitfalls. And this is due primarily to differential contraction or differential fixation of stromal tissues versus epithelial tissues. There is a greater amount of retraction, contraction with epithelial structures as compared to stromal tissues. These have more cytoplasmic proteins, cytoplasmic structures. These have fewer. And so the cross-linking creates this situation. Now, sometimes immunohistochemical stains looking for endothelial markers can be helpful if you have a question in a case like this. But you should be aware of this differential contraction and therefore these artificial cleft formation between tumor and stroma that is very prone to happen. Additionally, this carryover, this sort of called butter knife effect, can happen where the tumor gets pushed into spaces after resection that it wasn't occupying before you began to examine it. So here's an example. Nice vessel here, and we see red blood cells in the lumen and this chunk of tumor. Well, obviously this is large vessel tumor invasion into this vessel. Certainly the patient must be at risk for, metastasis. Well, you might think that, and certainly the blood cells help to suggest that possibility. But when you look at the tumor that was just above this, you see a tumor that's falling apart. It's fragmenting, it's breaking up. It even has a little bit of red cells associated with it. And so this very well could be a tumor that was deposited in the vessel as sort of a creeping into the open space opportunity as the knife passed through the tumor. Now, there are other ways to accommodate this. One is, of course, not sectioning until you have good fixation, or making clean cuts before you submit that tissue for processing. Alternatively, you can cut from the serosal surface towards the tumor so that you go through tumor last. That's maybe a little bit more problematic, but some efforts can be made on the part of pathologists to minimize this that include good knife hygiene and proper fixation. So the optimal criteria to define lymphovascular invasion would be the presence of, at the very least, an endothelial lining, plus or minus a muscular wall if it's a large vessel or vein. Finding some accompanying red blood cells can be helpful, not obviously absolute, as we just saw. The rounded contour of the tumor cluster that tends to sort of look more like a plug inside the tumor. And finding this in an appropriate location for lymphatics. So here we see the tumor bud here located right between two small muscular veins, and therefore this is a very appropriate location for a lymphatic. Lymphatics obviously will dilate if they fill up with the tumor, and so you should expect there be some contouring like this as we see. Now we also qualify in the endometrial carcinomas, whether the lymphatic invasion is limited or extensive. Extensive defined as more than 3 foci. But that obviously is somewhat observer dependent, somewhat sectioning dependent. And so how long you search for it, how carefully you search for it, what magnification and so forth, those can all influence how readily it's identified and determined. And it's okay in this setting to also say indeterminate or suspicious for, and provide what you see as evidence or what you may lack as evidence. All right, well, let's talk about another problem that frequently comes up and is a great bugaboo at times, and that's whether or not a uterine and an ovarian tumor are synchronous separate primaries, or whether they represent a metastasis from one site or the other. So looking back at a textbook from a few years ago, the dogma for determining that the endometrial tumor is primary and the ovarian is secondary suggested these 10 different criteria. So a metastasis will look similar to the primary. The endometrial tumor should be large and bulky, and the ovarian tumor smaller relatively. There should be some sort of a precursor lesion in the endometrium. Deeper myometrial invasion plus or minus direct extension or vascular space invasion, certainly higher risk for metastatic spread. And then spread elsewhere in a typical pattern of endometrial carcinoma, such as invasion of the cervix or lower uterine segment. Bilateral ovarian tumors or multinodular tumors are more likely to be metastatic in this setting. And if they're located in the hilus, have vascular space invasion or surface in some combination, again, more likely to be secondary to the endometrial tumor. There should be no precursor lesion, ovarian endometriosis. And if you get as far as being able to do molecular studies or DNA ploidy analyses, those should be similar in both tumors. In contrast, the much less frequent scenario where your ovarian tumor is primary and your endometrium is secondary tumor, these will also be similar tumors, but the ovarian tumor will be the large and bulky one, endometrial tumor smaller. There probably will be a precursor lesion like endometriosis or atypical endometrial hyperplasia in endometriosis. It'll be located within the parenchyma. There may be a history of endometriotic cyst or something of that sort. And potentially direct extension into the outer wall of the uterus or other types of patterns that suggest an ovarian cancer pattern of spread. These tumors are usually unilateral. Endometrioid tumors in the ovary in general are unilateral. And so a single mass type of lesion is going to be more commonly encountered there. No atypical hyperplasia or precursor lesion in the endometrium. And again, similar molecular genetic and ploidy analyses for the two sites. And then what we often are left with is the ones that don't fit those exactly, because we may not get all of these in either of those prior cases. And so we're kind of left to make our conjecture. But certainly dissimilar histologic findings would be helpful, different grades of the tumor and so forth. Superficial myometrial invasion is all you'd find in the endometrial tumor. No lymphovascular space invasion. Maybe accompanying atypical hyperplasia and absence of other spread, no cervical invasion, et cetera, a unilateral ovarian tumor, and it's located within the parenchyma, not on the surface, and does not show evidence of left lymphovascular space invasion and so forth. So these, again, you may be fortunate enough that your MMR or your immunohistochemical findings will be somewhat different as well. To sort of synthesize these, you have kind of your morphologic findings grossly. You have your staging findings that make a difference, precursor lesions, and then you're kind of down to the molecular and immunohistochemical findings that can be helpful in distinguishing primary synchronous tumors or metastatic tumors. Well, endocervical versus endometrial origin is also a challenge in some circumstances, and I think you should be aware of the standard way of differentiating these, as well as understanding that not every tumor is going to fit nicely into this scenario. So typically, immunohistochemistry is our fallback method after looking and seeing a tumor that looks, for all the world, like it could be of endometrial origin occurring in the cervix. But endometrial tumors will usually be Vimentin positive, monoclonal CEA negative. They'll have an endometrioid pattern of P16 staining, which is a kind of splotchy here and there cell positivity. They will be ER/PR positive most frequently, and they should express PAX8 in a vast majority of circumstances. This is for endometrioid tumors. Endocervical tumors usually are Vimentin negative, CEA positive, and the majority are HPV driven, so they're strong, blocky, P16 positive, negative for hormone receptors and PAX8. Well, this is all great and so forth, but there will be exceptions in cases that don't always meet the criteria. So here's one encountered recently in a tumor board in Southeast Asia. A patient presents with a bulky vaginal cervical mass. She gets biopsied, she gets some staging studies. It appears she also has an enlarged uterus and even metastases to nodes and lungs. And this is some of the morphology. Well, this is not a typical morphology. So this right off the bat should alert you that maybe our staining is going to be a little bit askew. So they reported results of CK7, P16 being positive, and CEA being positive. So that would, if we go back to our previous slide, that certainly sounds like endocervical origin. But in reality, as we looked at the P16, this appeared to be a more splotchy or patchy pattern rather than a blocky positive pattern. And so therefore, we're kind of left with ambiguous findings where the CEA favors endocervical, but some of the other findings maybe not so much. And certainly because we're looking at possibility for only focal NAPSA positivity, and negative finding for that result does not have as high a predictive value as a positive value does. So with that caveat in mind, just realize we do the best we can, and that's intended to get as close to the truth as possible. There are other times when the distinction is somewhat difficult or maybe problematic. Certainly non-endometrioid uterine cancers, serous tumors, and so forth. Non-HPV related endocervical cancers will have different staining patterns. Clear cell tumors, biphasic or mixed pattern tumors can also be kind of curveballs in this distinction. Let's talk about lymph nodes for a second or two, because this again comes to the point where we're thinking about measurements and the appropriate way to do that. So nice little schematic here shows that the distinction between a micrometastasis and a macrometastasis is 1/10 of a millimeter. Okay, so knowing the variations in measurement, that's a significant or easily missed or mismeasured sort of distinction, depending on the level, depending on the orientation that you choose. Having said that, micrometastases and macrometastases are still staged as N1 disease in most circumstances. What are not staged as N1 are isolated tumor cells. And so treating them appropriately is very important. Now, isolated tumor cells are defined as less than 2/10 of a millimeter. So if this is our isolated tumor cell and we don't have any of this other stuff here, this is an N0 I positive case. Now, sometimes you'll see isolated tumor cells in more than one location. And so the question is asked, well, does that raise your distance? And you measure that. And if we measured these 3 in a row, well, that would give us a macrometastasis. Well, if I can be so bold as to say, don't do that. that is not the correct way. Isolated tumor cells, each individual site is what is measured, not an aggregate of multiple sites over a particular distance. Even if they're fairly close, that is not the right way to do it. And similarly for the macro metastases versus micro, maybe getting a couple of levels or making sure that you're measuring the largest diameter is the right way to go in this situation. So next slide here. Oops, need to erase here. Just erase that. So as we think about things that can be disconcerting when we're dealing with serous tumors and we find these Mullerian inclusions in pelvic lymph nodes, they can be quite disconcerting, particularly if our tumor is a borderline, well-differentiated, low-grade tumor. But it's recognized that these Mullerian inclusions are frequent findings in pelvic lymph nodes and often can be distinguished by the presence of cilia here in these lesions. And since borderline tumors are not upstaged by the presence of regional lymph nodes, it's really not a critical distinction in terms of staging. Maybe alerting finding for potential follow-up, but not in terms of overall staging. What we've had happen on occasion, however, is you get benign inclusions like this on one area, and then just off the screen here, you've got the borderline tumor in an inclusion or in an area like this. So that, again, becomes a little bit problematic, but using morphology, you can also make that distinction. Now, another uncommon but problematic lymph node finding is the presence of NEVA cells in the capsule of the lymph node. These are S100, SOX10 positive cells that are typically present in the fibrous capsule of the lymph node. And ordinarily, we recognize these easily for what they are, but in the setting of an inguinal lymph node dissected in a patient with a vulvar melanoma, they can be more challenging to differentiate. So lastly, I'd like to spend a few minutes talking about patterns of invasion that may have some therapeutic implications. We'll talk particularly about Silva system and the MELF pattern of invasion. So the Silva system was proposed for endocervical adenocarcinomas, and in their original description, provided this description of pattern A. So we have pattern A, B, and C. The pattern A tumors have no destructive invasion, well-demarcated glands, no single cells, no lymphovascular invasion, no high-grade cytology, and any complexity is less than a 4x field. So this is kind of some standard images published to represent pattern A. You see well-demarcated, rounded nests. You don't see desmoplastic stroma, maybe a little inflammation, but that's okay. But no destructive invasion, no confluent growth. Pattern B has a localized or limited amount of destructive stromal invasion arising from well-demarcated glands. There may be some small clusters separated from the rounded glands, and there's usually an inflamed or desmoplastic stroma, but limited in extent. These can be multiple at the base of the tumor, but are less than a 4x field. So there's a very limited localized size. You may occasionally encounter lymphovascular invasion. So here's a representative image. Again, here we see mostly rounded growth, defined growth. But then here we see a little bit of area of inflammation, which as we look over here, we see some fragmented, detached glands. And as we look at this section, again, pattern A, isolated focus of lymphovascular invasion. So these are the features that might push us to pattern B. In contrast, pattern C has more generalized or diffuse destructive invasion, variable size glands, angulated. It may have confluent growth with little intervening stroma or mucin lakes with tumor cells within the cervical stroma that are greater than a 4x field, greater than 5 millimeters. It can be a solid type, or it can be diffuse laminar endocervical adenocarcinoma greater than 5 millimeters, and may have this sort of band-like lymphocytic infiltrate indicating an immune response. And this may even obscure the neoplastic aggregates. If you have micropapillary pattern, that also would fit into this category, and lymphovascular invasion can be present. So here on the right is our confluent viloglandular pattern of growth. That fits into pattern C. Here's our angulated destructive glandular stromal destructive pattern with areas of lymphocytic response, and here more confluent patterns diffusely evoking this stromal change. So these are, described patterns. Putting them into practice, does that make any difference? Well, at least according to the data, this is sort of a synthesis of several studies looking at over 1,000 patients, classifying them according to pattern, and then follow up on these patients. As you can see, lymphovascular invasion was absent in pattern A, and none of them had lymph node metastases. Additionally, they had no recurrences, and none of them died of their disease. So if you have pure pattern A invasion, even if it may be at stage 2, you're probably in a pretty good group. In contrast, as we go through pattern B and pattern C, the statistics get progressively worse. It's still not really bad if you have pattern B, but you do occasionally have patients pass away, you have recurrences, and you may have a few higher percentages at higher stage. In contrast, here with pattern C, a very significant number present with recurrences or advanced stage, and much higher proportion have lymph node metastases. So let's move on to endometrioid carcinoma and talk about patterns of invasion here. I won't go into great detail to talk about this overall, because the majority of these don't seem to have much difference. But pushing invasion or adenomyosis-like invasion, or so-called adenoma malignum type of invasive patterns can be seen, where you have well-differentiated isolated glands just departing from the normal tissue. But the area we want to comment about is the so-called MELF pattern, and that stands for microcystic, elongated, and fragmented glands. And so here you see this pattern. These are small cystic glands, somewhat fragmenting, and again are evoking a desmoplastic response in these scenarios. So small cysts, angulated, elongated glands, oftentimes have kind of pointy ends, and they may be fragmented. Well, does this make a difference? Well, in fact, it does, at least in some studies. This study looked at those with just pure MELF pattern invasion versus any of the other patterns, 18.3% with lymph node metastases versus only 1.2% in non-MELF patterns. And this was irrespective of stage. And at least a suggestion that the time to non-vaginal recurrence was shortened in these MELF pattern patients, and micrometastases or isolated tumor cells were more frequent in those circumstances as well. So these are something that we are trying to add to our reporting data, the endocervical invasion pattern and the endometrial invasion pattern, to provide some realistic indication of where our patients may fall in regards to these published studies. Well, with that, I'll come to the end of this, and thank you for listening. Hopefully I didn't make things more fuzzy in doing that. And if you like this, I certainly hope that you'll hit the like button and maybe share it with your colleagues who are preparing for GYN oncology boards, or otherwise trying to bone up on some of the pathology issues that come up for consideration. And take some of these things into account when you're dealing with clinical decisions on patients with measurements that are very close to certain thresholds in particular. So until next time, thanks so much for joining me.